appreciate you guys joining us on this Thursday. As Lauren mentioned, I am switching focus. I feel like a lot of our Caribou talks are adult focused and involve a lot of basic science. So hopefully I will stretch your brains to think about pediatrics and a little bit more from a clinical standpoint, because that is my world. So welcome to it. Let's go. All right, so pediatric voiding dysfunction, just a little bit of background there, since again, I know a lot of us work in the adult realm. So pediatric voiding dysfunction, or LUTS in children, affects up to about 47% of all kids, which is a huge group. And our standard first line treatment therapies, just called standard urotherapy, only treats about 25 to 45% of these kids, which really just means there are a lot of kids who need secondary or second line or third line therapies, of which they are rather limited at the present time. We also know that there are several comorbid conditions specific to the pediatric population. Those include ADD, ADHD, anxiety, depression, abusive attitudes, and obesity. It's also always important from the pediatric standpoint as clinicians to just kind of know that the second most common time for any kind of child abuse act to occur is actually during toilet training. So the first peak is in kind of infancy. If you've ever had a child and they scream a lot in infancy, it's a terrible thing to say, but you can kind of almost understand, some of that anxiety that comes with having a newborn. And that same anxiety with parents kind of comes again right at toilet training. So there's a lot of stress put on to families to have kids toilet trained by a certain age, whether that is culturally or from schools, daycares, et cetera. So this is the second peak that we see in pediatrics for child abuse. The definition of continence for children, it's normal attainment is defined as being age 5 and older. To be able to say that you have attained urinary continence, you need to be continent of your urine by age 5. And for bowels, you need to be continent of your bowels by age 4. And that is kind of the normal attainment. We can't officially diagnose you with any of these urologic conditions or like encopresis or functional encopresis at a younger age than that. And this is set out by the International Continence Society for Children. The mean age for continence, though, is different than this. So for girls, the mean age for urinary continence is about 2.5, and for boys, it's about 3.5. So there are many, many children who are going to be continent of their bladder and their bowel well before these ages kind of arise. So conditions, the main conditions are very similar to what we talk about in adults. You've got your OAB, your overactive bladder. You've got underactive bladder, although it is rare in adults. I think it is even more rare in the pediatric population. We've got dysfunctional voiding. So again, just those detrusor contractions during voiding against the closed urinary sphincter. That is very popular and more common in the young females in the pediatrics group. We also have nocturnal enuresis, or your classic bedwetting. I'm not really going to get into that today. That is a whole nother lecture. There's, different origins and different treatment managements than our standard LUTS. And then urinary tract infections, which can be, people can be predisposed to those because of some of these other conditions, or kind of in reverse, having UTIs may also start to cause some other dysfunctional voiding, et cetera. So we will touch on that as well. And constipation. You cannot go into pediatric urology if you don't have a sense of humor about poop, because you will spend most of your career talking about poop. So until proven otherwise, all children with bladder disorders are constipated. And I just put 3 of the top kind of theories behind this association. Their rectal distension, when you have a full rectum, just causes bladder neck and trigonal compression. And that's just through the posterior bladder wall, which causes increased pressure and kind of frequency urgency, but also can decrease the ability to adequately and fully empty your bladder. So you may have an elevated post-void residual from that. You also, one of the theories is urethral and anal sphincter neural input. It's really just one functional unit, with the same reflexes coming down to the bowel, the bladder, and the proximal urethra. So of course, if you're going to have an issue with a neural input into your bowel, you're likely also going to have an issue into the bladder and vice versa. And also any kind of prolonged external anal sphincter contraction. So children who have functional constipation, they withhold their stool, and they now have a large retained amount of stool in their rectum. This is going to cause an inappropriate kind of pelvic floor muscle contraction across the board. And therefore, again, tightening the back end, as I tell patients, will invariably tighten up the front end and make for a dysfunctional voider. Okay, so enough about the background that you guys probably largely knew, but treatment. So the treatment in pediatrics is different than in adults. Although people always like to think that kids are just little versions of adults, they're not. They have different developmental structures. Everything is changing. There's a lot of different variations. So we have to think about our treatment in peds differently than we do in adults for those reasons, but also because the FDA thinks of them differently. So we don't always have the same options that are available to our adult colleagues for similar conditions. So our first line, like I mentioned, our standard urotherapy. This treats, again, 25 to, I think it's 47% of our patients. It's really just your proper hydration, which we calculate loosely as about 1 8-ounce cup of water per year of age until age 8. Timed voids, all of us on here should be peeing ideally about once every 2 to 3 hours while awake. So hopefully you went either before this or will go after. And proper toilet positioning. Squatty potty is obviously a popular product, but you can also use a stool, boxes, books, whatever, to try to help children. Particularly in kids, we do focus on toilet positioning, I think, much more than we do in adults. And in large part, little kids, once they are off the little potties on the floor, they just get put up on big toilets, and their bottom is tiny, so they need little potty rings so they don't sink in. And additionally, their legs are short, so their legs aren't hitting the floor. So we need something to help give them support and help the anal rectal angle. And then I haven't talked enough about poop. First line therapy always will involve some sort of bowel management to make sure that constipation is not a compounding aspect. So then we got our second line treatments. These are our medications. The first and foremost that we're most familiar with, your anticholinergic meds. In pediatrics, these green medicines are the only ones that are currently FDA approved for the use in children. And with that said, mirabegron just got joined onto this list in March. It is now FDA approved in children and also is coming in a liquid form as well, which is very exciting for us. So we have oxybutynin and sulfaphenacin as our main anticholinergics. There's a lot more resistance coming now from families about these medications. There was a New York Times article now several years ago, but it still seems to kind of circle back into our world about potential associations with oxybutynin and dementia in later life, and also memory problems in children. So this is really kind of paused a lot of practices prescriptions. There's just a lot more people who are resistant to starting these medications, and rightfully so. And then again, now we have mirabegron, which has been added to the list, but is newer to our therapies and still isn't getting great coverage by insurance companies. There's a lot of prior authorizations required still. I'm going to call these our second-ish line therapies. They are technically all still second line therapies. There are pharmacologic agents, but they are not FDA approved for pediatric use. I have been part of a clinical trial for fesipheteridine in the past to try to get that changed, but that has not yet happened. And then we have tolterodine and tripsium. So again, they are commonly prescribed in peds, but technically not FDA approved. And this leads me to our third line therapies. So currently, kind of the accepted third line therapies that we are using are Botox, TENS, and PTNS. So for Botox, Duke has been part of the multi-site trials for Botox in peds for children without neurogenic bladder. And actually my prior institution at UC Irvine, we were part of it over there as well for the neurogenic bladder population. So it's been kind of fun to be part of that ongoing clinical trial for Botox, both in both neurogenic and non-neurogenic populations. And I think we are, making really good progress regarding safety and efficacy and correct dosing and follow-up for kids, but that has not been fully cleared. The other big consideration with Botox, because again, it's still used, is in kids in particular, two things. One, we do Botox under general anesthesia in children. Once they hit 18, it's often that we'll do it in the outpatient clinic setting without any anesthesia. But in children, it's general anesthesia. So that tends to be a barrier. It's hard to get families to sign up to put their kid under GA every 6 months or so. So that can be a big barrier to use. And the other is the high potential to need catheterization directly after. It might not be long-term, but it could be for a few days, a few weeks, et cetera. And that's not terribly uncommon after Botox. And if you have ever been acquainted with children, and you will know that putting a catheter in them when they are otherwise never had a catheter or needed a catheter is not exactly something they're going to willingly want to do in most cases. So once you bring that up as the potential side effect, it turns a lot of families and a lot of the kids off. And of course, we're not going to do this without, the kid wanting us to do this as well. So the chance for catheterization really, I think, is going to limit how far Botox is going to go as a third line therapy in peds. TENS, the transcutaneous electrical nerve stimulation, kind of similar to your PT pads that you might get in STIM. And this is definitely also used, not very commonly because the success rates in pediatrics compared to placebo in several studies have really been rather poor. It also tends to have decreased success when you compare it to PTNS or Botox. So I think there's still some utility to it, especially for patients who maybe live very far from their clinic or in a more rural setting where it's going to be hard to get frequent visits to their clinic. There may be some utility there if it's working, but again, its success rates haven't been published to be high enough yet, I think, to be widely accepted as a third line therapy. So I'm dwindling this down to PTNS, Percutaneous Tibial Nerve Stimulation, which is what I'm going to talk about more. So if you're not familiar with PTNS, I don't have one with me. I wasn't in clinic today, but it's similar to the size of an iPhone, a similar phone device. And it's a little white remote that is connected to a small, a little wire that really is just connected to a tiny needle. And the needle is really a acupuncture needle. So it's very, very tiny, very, very fine, actually not very scary, even to young children, because it is just so small. It's kind of like a thread of hair almost. So the posterior tibial nerve, it's located on your medial, in your ankle, but we go from the medial side when we are putting in our needle. And this nerve is obviously derived from the L4-S3 nerve bundle, which is also responsible for a bladder detrusor and pelvic floor innervation. So we're basically trying to activate that set of nerves, but doing it via the posterior tibial nerve. And this is a pretty well accepted practice. It's part of the AUA and the SUFU guidelines for treatment of OAB. They both have it listed as part of their third line treatment agents, and it's listed right up there with sacral nerve modulation, PTNS, and Botox as kind of third line therapies without hierarchy to them. So there's great evidence in adults right now regarding efficacy here, but not in pediatrics. And in adults, in adults, the success rates for treating and improving OAB are upwards of around 80%, which is amazing. But we're really, really lacking in our pediatric studies for this, both in regards to safety and for efficacy. So currently, the FDA 501(k) is age agnostic, which was a term I was not familiar with when we first started talking to the FDA about 2 years ago about PTNS in children. So it's basically just meaning that it does not confirm nor deny that we can use this in pediatrics. Instead, it just leaves it blank, and it does not specify an age range that PTNS can be used, but essentially all of the evidence behind it and published data that the FDA puts out, et cetera, and to support PTNS is all in adults. So there's nothing there for pediatrics, which largely has left it not an option for most academic centers, for anybody who has insurance, because insurances don't generally pay for this, or if so, it's a rather large hurdle to do so. So there's a lot of barriers. So because of that, and because we really believe that this is probably our best current third-line therapy for pediatrics, we have been partnered up. My team's been partnering up with the Pediatric Trials Network. This is housed under the NIH's NICHD, and we are putting together this protocol. It's called Defining the Safety and Efficacy of Posterior Tibial Nerve Stimulation in Children, or slightly less of a mouthful, positron C. So this is a currently funded study that we have. I am the PI on this for us, and it is going to be a multi-site trial. And some of the regulatory information for this, PTNS, we're using, there's several devices actually out there in industry for PTNS delivery, but we are using the Urgent PC device, which is from Labary. It's just the most commonly used device out there. Oops. So this is a class 2 device. In order to kind of move forward, our goal again is to eventually get the FDA to switch its labeling and really endorse this for peds. So we've been meeting with the FDA, and they've been helping to tell us exactly what we need to do and make sure that our study is covering in order for them to consider expanding the labeling. So the pre-market approval, it's called the PMA, and 510K approval letters, again, they're age agnostic, which is really limiting our pediatric use. And the FDA says that basically we can go ahead and try to do a study if we believe that the current information is not sufficient for pediatrics under any of these 4 bullet points. And I just highlighted in red the ones that we're focusing on. So the supporting information out there from sources such as adult clinical trials are just inadequate to establish safety and effectiveness for the pediatric indications. So again, adults and kids, they're not the same people. Their anatomy is not even perfectly the same. So we really can't extrapolate that, especially down to kids as young as age 5. The adult data is currently inadequate, again, to predict pediatric risks and adverse events. So in the same line there with safety, we just can't assume that's what's happening in adults is what's happening in children. And so those are the 2 targets we have that we need to switch over from a regulatory standpoint. Our objectives are here. Our primary objective of this study is really the safety of the Urgent PC, which is just our PTNS device for children with OAB. Our secondary objectives, we're going to look at the actual change in OAB symptoms. So is this a little bit of an efficacy as well? And we're going to describe adherence to Urgent PC. Currently, the treatment is once weekly sessions for 30 minutes for 12 weeks. And I think this is difficult for any schedule, but especially in children, this tends to, we're assuming this may be an extra barrier because you're not just dealing with a parent schedule, but it's a parent schedule plus a child schedule, plus school activities, school in general, et cetera. So we really want to get an idea on the adherence and practicality of administration. We're also going to look at the quality of life of children with OAB before and after, and hopefully, again, associating with improvement in symptoms. And we've got a couple exploratory objectives as well. We are going to collect urine, looking at some biomarkers to OAB symptoms, and also describe the maintenance period. So for PTNS, even in adults right now, there's a really well established that once weekly for 12-week therapy as your initial treatment, but the maintenance thereafter is sort of up to the clinician and the patient. So that hasn't been well defined. And we're not looking to define that in the study necessarily, but we are going to try to capture some general information to lead us in the future about what might be the best kind of maintenance therapy out there down the line. So our inclusion criteria, this is going to be for children, boys and girls, 5 to 18 years of age, and this is inclusive of age 18. They have to have history of either primary or secondary non-neurogenic OAB. In kids, we're defining this largely by the Vancouver symptom score. This is a validated questionnaire. It's rather not labor intensive for the kids and the families, but it's just a questionnaire of symptoms that if you have a score of 11 or higher, kind of diagnoses you or with LUTS. So we're using this as our qualifier, as well as a positive bother score, which is modified from the AUA bother score. So it's a single arm cohort study. 50 participants is our goal for enrollment. It will be open for enrollment, hopefully in a month or two, at 5 sites across the United States. And again, the initial study is once weekly treatments, 30 minutes per session for 12 weeks. We will be following up again at week 16, just as a safety measure, but also again to try to characterize what type of maintenance was needed to keep symptoms at bay during those 4 weeks after treatment. It's a little bit busy, I'm sorry, but this is our protocol in general. It's largely going over what we just talked about. We are, at your screening baseline, your general consent, demographics, physical exam, medical history type of information that we would normally get. The quality of life measure that we're using for this study in particular is the PIN-Q. It's the Pediatric Incontinence Questionnaire. It's specific to quality of life in the pediatric population for incontinence. So we're pretty excited to use that. This is a list of the biomarkers we'll be using, the biomarkers we're going to be collecting urine from at the beginning of the study, and then again at the end of the study, and hoping to see if we see any correlation patterns or associations there between symptoms. These were all pulled from other studies that have looked at either bladder inflammation or overactive bladder in adults or in rodents. So it is kind of a large net we are casting out here, but again, this is one of our exploratory aims. Okay, so now I'm kind of shifting gears because I was giving your undivided attention for a little bit, a decent amount of time tonight. So I did want to kind of jump into a little bit more of a different study that we're looking at today that's focused more on urinary tract infections in children. So again, still under that same umbrella, but a slightly different skew. So how does the urinary microbiome affect these conditions? Obviously, we don't know. I'll spoiler alert, we don't know. There's obviously a lot of work that many of you and others are working on to look at different correlations with the urinary microbiome. Again, most of these studies so far have been in adults. We keep leaving these kids out. And I think that's a shame because, one, I work in pediatrics. 2, because I think a lot of these microbiome changes and eventual conditions that we're seeing in adulthood, they're probably stemming from changes in the microbiome in childhood. And we don't have any real characterization yet of a microbiome in a healthy child. And then how is that evolving and how is that maturing or changing into adulthood, which then might be causing these problems. It's also interesting to look in children because just by root of their age, their microbiome is going to be different. It's a little bit more, hasn't been exposed to as many things as an adult has, probably less medications, less surgeries, less environmental toxins. Their diets aren't quite as varied yet. There are so many pieces that come in and will kind of pollute our ideas here or pollute the microbiome potentially of adults that maybe are not quite as pronounced in children. So it's a really interesting area that we are starting to look into. And specifically in Caribou and LUTS in the world of urology, we want to look at any associations between recurrent urinary tract infections and this composition of the urinary microbiome, because we already know that some of those associations do exist and we're identifying them in adults. So I want to see if we can see those in children as well. So again, there's just this giant gap of knowledge between around the composition and development of the urinary microbiome in children. So very thankful to Caribou, myself and Dr. Tatiana Saisova and Dr. Lisa Karstens. We were awarded the Caribou Collaboration Award this past year, which initiated in July of 2021. Dr. Sayasova is a PhD. She's down at the University of Alabama, Huntsville. She's a microbiologist and actually a former K-12 scholar as well. And then Dr. Lisa Karstens is a PhD. She's a bioinformaticist over at Oregon Health Science University. So the three of us are kind of a new team. We're really excited to kind of bring the clinical perspective, the microbiology, and the bioinformaticist perspective to this, the child microbiome field. So the aims of our Caribou Award, aim 1 is to evaluate the microbiome presence and composition of urine of children down to a species level resolution. So really the big innovation to this aim, we are testing the feasibility of a novel sequencing approach called loop-seq, loop sequencing, which Lisa would probably kill me if I tried to explain it. But if I understand, it takes various amplicons of the full 16S sequence and really doesn't dilute the sample much at all. So you can get a really good species level characterization of microbes down to a very small biomass. So we have done studies on this and used air and used water. And now we have actually used some urine samples to show that even in these really low biomass specimens, we're able to get great DNA out, great DNA and microbes kind of characterized out all the way down to that species level, which is pretty novel. We wanted to try this as well in catheterized urine in children, because again, in catheterized urine, you're not going to get pollutants of any microbiome from the skin, genitalia, GU, or at least not as much. And we're probably going to have a rather low biomass of microbes there. So if this works well in this group, we're really excited. I think it's going to really open up different options for us. So we have 50 catheterized urine samples. These were all taken from children under age 2. Some had urinary tract infection history, some did not. We were able to capture these samples before they underwent a voiding cystourethrogram, which is just a study we do with a catheter. So we were able to capture the spare urine for these children. So we have those samples, we filtered and froze them, and they're currently getting sequenced at Loop right now. Our second aim is to compare the urinary microbiome in a pilot cohort of children, a group with and a group without urinary tract infections. So here, we're looking at slightly older kids, not just these little babies, but looking at children who are continent, so age 5 and up, but also pre-menarche. So up to approximately age 10, 11, 12. If they have had their first menarche, we are not including them, as we know that that will change the flora that we will likely find. So we are asking these children to provide us with voided urine samples. And I know whenever I say that, a lot of people go, and they sit back. But we really think it's important because we're looking, our end game here is really urinary tract infections. And what causes or what bacteria is really causing a urinary tract infection might not have an origin solely in, the bladder. It might come from, the vagina, it might come from the skin. It might come from something from the GI tract that kind of colonizes. So by getting a voided urine sample in these children, we're really going to get kind of a nice sample of what's going on there. And if we can correlate that to, some bug, and I don't know exactly which organ it came from, is causing these UTIs, well, that's vital for clinical treatment. And then sure, you can creatively go back and figure out where it came from. But I think what was most important for us clinically is to just find out what might be predisposing us to infections or what might be protective from infections. So, and so just a little bit about kind of the methods we're using for both of these aims for the urine filtering and kind of washing out. So we're collecting the urine and then doing a filtering, vacuum filter, and then basically freezing those in our deep freezer. From that point, we are then using a blood and tissue kit to get the DNA off. This is from a study looking at 5 different DNA isolation kits. And the DNA was extracted from 11 different urine samples. And this blood and tissue kit here really recovered significantly more DNA than the others. So this is the tissue kit that, or the kit that we are using to pull off our DNA. Here, this is talking a little bit about the differences between the different types of sequencing. So again, going back to kind of our innovation factor, which was using this loop sequence for looking at the bacteria or the microbes in urine. So here's just the traditional V4 sequencing, and then here's loop-seq. And you can see in our pictures, we've got the relative abundance of bacterial species from a mock microbial community. And this was diluted. So, most concentrated to most dilute, and it's the same samples on both. The purpley tones are all kind of the expected taxa that we would see. And all the unexpected or kind of contaminants are the remainder of the colors. So just by looking, you can see that the V4 had a lot more contamination when you started to get to the more dilute samples, and it remained rather stable and much less in the loop sequence. So this is pretty exciting for us because we think that these more dilute samples are better mimics of the low biomass that we're going to expect in our urinary samples. And so by using this kind of new technique, we're hoping to limit the contaminants that are there as well and get better samples. Okay, so where do we go next? Lots of places. There's so many places to go. But currently our team, Lisa, myself, and Tanya, we have submitted another grant to investigate more about the temporal stability of the pediatric urinary microbiome. Again, it's really important that we understand how quickly the microbiome may change in the pediatric population before we can really start making associations about, the presence of something and whether or not it's related to your predisposition to a UTI or protection from. And also in peds, we're expecting that we're going to have to do some home collections. It's just not always realistic to have people coming in frequently for urine collection. So we're testing out some different home urine collection techniques and comparing those to kind of in-house collections and seeing if we can find any significant differences there. And we're hopeful that by the end of these grants, between the Caribou and the currently submitted grant, we really will have a sound methodology that we can use for not just the collection of the urine, but also its storage, its filtering, the DNA analysis, et cetera, the sequencing of it, so that we can really now go forward and apply for larger studies that will really start to investigate these variations and these associations in the microbiome of children with and without urinary tractants. And this will make for much stronger studies, we hope, down the road. We have two main long-term goals. One is really, we want to develop a predictive urine test to help identify those who might be at risk for recurrent UTI. So it would be great to know in advance these kids, and especially if we can also complete aim 2, or our second goal, which would be to develop a non-antibiotic intervention for treatment and prevention of UTI. So if we do find some protective microbes out there, then this would be fantastic to be able to identify who's at risk because of the microbes already present, and then helping to kind of populate it with more protective microbes down the road. Obviously, these are long-term goals, but it's kind of where we as a team are aspiring to head, and hopefully will be useful for the adult population as well. And that's what I have.